Hello, welcome. Thank you for joining us for our session on the France Arcade trial for VEDS. My name is Ryan, and I am the director of the VEDS movement here at the Marfan Foundation. I am honored to be joined today by Dr. Xavier Jounmet. Dr. Jounmet is the professor of genetics at the University of Paris City, as well as the head of genetics department at Georges Pompidou European Hospital. If you have any questions for Dr. Jounmet, there will be some time for a Q&A at the end, so please do submit those questions via the Q&A function of the Zoom webinar. And with that, I will welcome Dr. Jounmet to the stage. There we are. Welcome, Dr. Jounmet.
Welcome. Thank you very much. And thank you very much for this invitation to speak about what we have begun in Paris, in France, about the use of an angiotensin II receptor blockade in VDS. Actually, this is probably the first double-blind randomized placebo-controlled trial in this pathology. And just would like to give you some introduction about it, and then the main results that we have for the moment. The context of this trial is the following. We know that VDS has relatively high arterial morbidity and mortality, and that we need some medical management in terms of preventive management, as well as curative management sometimes. And so if you look at the literature, and if you look at the way that in different countries the people have been followed and treated, you have multiple therapeutic experience and survey when you look at it. You have a use of a particular beta blocker, which is celiprolol. We can speak about it in another session, through an open trial 15 years ago almost, with the BBAS trial, which showed positive results about cardiovascular morbidity and mortality. We conducted a French open survey on more than 140 patients, which seemed to observe quite positive results also with the treatment. Same thing for a Swedish survey, which is 40 patients, and same thing also for an Italian survey, which has been more recently published. But each time, I would say that when you look at it, you see that you have probably a decrease of symptomatic arterial events, but something with a pathology still going on with, as we will see, some dissection aneurysm still going on, even though they are asymptomatic. So in addition to celiprolol, you have other therapies which have been used in different countries, especially in UK or Dutch or USA, which are other beta blockers, angiotensin II receptor blockers, inhibitors of the angioconverting enzyme, or calcium channel blockers, CCB. Unfortunately, there has been no randomized placebo-controlled trial for this different type of therapeutic. So each one of us tried to treat the patients as the best as possible, I think, but we have no perfect medical evidence to treat by this drug or the other one patients with VDS. The second thing that we know is that when you look at the patients, at least those who are coming in the specialized centers, we see on total body angioscanner, that CTA, that most of them have already asymptomatic arterial lesion, more than 70% of them. And when we, in our experience, when we count the number of lesions per patient, it's approximately 5 lesions per patient, mainly dissection or aneurysm, but sometimes also stenosis or occlusion. And we made the effort 10 years ago to look at, in an open way, the follow-up of patients with celiprolol. And we see that looking at the second CTA about 2 years later, and we have no change in 37% of them, but a change in more than 50% of them. Most of them, it was an aggravation with a new lesion or progression of pre-existing lesion, but sometimes also improvement. Interestingly, the arterial lesion might be improved or disappear sometimes. And you have some patients who have discordant evolution with not only improvement, but also worsening in some lesions. So it's not easy actually to look at exactly the follow-up of each patient. The third thing that we know is the influence of angiotensin II in that disease. When we look at this mouse model that we have performed and looked at, investigated, you see that if we are looking at the dose increase of angiotensin II in this knockout heterozygote mice, oops, excuse me, it was the previous one. You see that you have an increase in mortality in these mice as soon as you give a certain dose of angiotensin II, and a very strong increase in mice. They are not surviving more than one week if you increase the dose of angiotensin II and you increase in the same time blood pressure. So you have a toxic effect of angiotensin II, which is not only by increasing blood pressure, probably, but an angiotensin II mechanism. And in another mice, which is heterozygous mice, we have the same effect. If you look at the mortality with angiotensin II, you see that you have a very strong increase in mortality with angiotensin II. More than that, when we look at the effect of blocking angiotensin II by an IRB like losartan in mice, then you have a very beneficial effect, at least in this model. If we are looking at the right part of it, you see that spontaneously these mice are dying, approximately 50% of them in 24 weeks in male mice. And if you are giving losartan at 5 weeks of age after weaning, you completely suppress the mortality in this small number of mice. And we had the same thing before when we are giving losartan before during pregnancy of the mice. Interestingly, when we look at the arteries themselves, it seems that blocking angiotensin II do not protect completely from dissection, but it protects from rupture. And you have chronic aortic dissection that you can observe in some of the surviving mice. The final part of the context of this trial is that we have the chance in France to have a network of different centers which are following patients, and therefore to be able to conduct a multicenter study, trying to have the same kind of medical management in each of these centers. And it was the idea of this ARCAD trial. So, to be brief, we had launched this trial, which is called ARCAD trial. The idea was to mainly have first an initial workup during a few weeks with the stabilization of the patients, with a molecular diagnosis and also with a CTA, and to follow these patients for 2 years with a vascular monitoring every 6 months for a Doppler ultrasound, but also every year with a CTA. And like that, we would be able not only to count the symptomatic event, but also the asymptomatic event. And the idea was to give either placebo or irbesartan in a double-blind fashion. So not only the patients are not knowing what they are taking, but the physicians are not knowing either what they are taking. So it's a multicentric double-blind placebo-controlled trial. The ARB that we used was irbesartan, it's a long-acting ARB. And in France, since celiprolol is a drug of reference, everyone was taking celiprolol. So it was on top of celiprolol, either irbesartan or placebo. We had a running period for 1 or 3 months, just to be sure that everything was stabilized in these patients. Then an inclusion in initial workup, a titration period for 1 or 2 months. The idea was to give irbesartan a half dose, 150 milligrams at the beginning to 300 milligrams, if tolerated. Same thing for placebo. And as I showed you before, we had these visits, regular visits for 2 years, and especially imaging techniques at 0, 1 year, or 2 years. The study duration was about 5 years, 2 years, 2.5 years of inclusion, plus 2 years of duration of the protocol itself. And the primary composite outcome was the symptomatic cardiovascular events and the asymptomatic arterial lesions. We knew that we would not have sufficient number of symptomatic cardiovascular events, taking the experience of the different survey and trials. And it was necessary to have a combination of not only the symptomatic, but also the asymptomatic arterial events. We had an hypothesis of a difference between irbesartan and placebo that you can observe on this slide, 20% versus 45% events at 2 years. And we calculated that we would need about 100 patients to achieve 80% statistical power. And the idea was stratification by centers and type of variants. Of course, there are different type of committees with classical multicenter randomized trial, clinical trial. Just to give you an example of the primary composite event, you have on your left an occlusion of the right renal artery here, and you see an infarct of the right kidney, a partial infarct. And so this is a symptomatic event, and this is an asymptomatic event where you can see there on this slide the fact that you have a dissection of the iliofemoral left artery, which is not symptomatic in that case. The patient did not have a particular symptom with this dissection. Unfortunately, we didn't get as many patients that we hope. We only assigned for eligibility 61 patients, so 57 for randomization, and either to irbesartan, allocated to irbesartan 29 or to placebo 28. And it was an intention to treat analysis, and we had no follow-up, no loss to follow-up except one in placebo. That after 1 month just stopped the protocol. You have there the characteristics of the patients. Classical characteristics for the VEDS patients, approximately 40 years of age. We had a predominance of female patients, 65% approximately. Body mass index, which is low as usual, about 22, 23. Blood pressure, which is relatively normal low, about 120 for systolic and 68, 70 for diastolic. A normal renal function. And you see the different type of genetic variant that we've got, about 80 to 90% of what we call dominant negative mutants, either glycines or glycite, and the other one which will stop indel or frame shift. And we're at approximately 65% of index cases and 35% of relatives. As you can see, we had a majority of patients who had already arterial lesions, more than 80% in both cases. Some of them had already digestive complication, 20% approximately, even some pulmonary event as pneumothorax, 10% approximately. The dose of celiprolol that they were taking was about 320 milligrams, 350, 60 for the other ones. And you see the range, but most of them, approximately 2/3 to 3/4 of them were taking a maximal dose of celiprolol. No cardiovascular risk except some case dyslipidemia, and the arterial lesions that were observed in the initial CTA were present in more than 80% of the case, and mainly diffuse lesions, either supraortic, visceral, or iliofemoral arteries. The first thing that we observed at the analysis of the trial was the fact that when you add irbesartan to placebo, you decrease blood pressure. and you decrease blood pressure quite powerfully, I would say. You observe approximately 8 to 10 millimeters of mercury of difference for the systolic blood pressure, and also for diastolic blood pressure, you have 6 to 5 millimeters of mercury of difference at the beginning. After that, you have an equilibrium, since some patients also had an adjustment of their posology, since the blood pressure was not always well tolerated. When you adjust the difference in terms of systolic blood pressure, for example, during the trial, adjusted on age and sex, you see the difference that is approximately 7 to 9 millimeters of mercury during the first 6 months, and then approximately 5 millimeters of mercury after that, which was quite significant. And same thing it was for diastolic blood pressure. So it's interesting to see when you combine irbesartan and celiprolol at full dose for more than 75% of the patients in the study, you get symptomatic hypotension in some cases. You see that we had 4 women with symptomatic hypotension, leading to down titration in 3 of them. And we got also 9 cases, 2 men and 7 women, who during the survey had a systolic blood pressure less than 100 millimeters of mercury. And so it says that the antihypertensive effect of this combination in VEDS patients is quite powerful, and probably that it's important, especially in women, to adapt the dose depending on the tolerance of the medication. So what about the occurrence of symptomatic arterial event first? You see that we did not observe a large number of events, 6 events in the placebo group, 3 events in the irbesartan group. When you look at it, you see that the events in the placebo group were already occurring approximately at 8, 10, 12 months of survey, and after that during the second year. When you look at the irbesartan group, only 3 events, and they were mainly at the end of the trial, so it seems to be protective in terms of time. When you look at the combination, which was the primary composite endpoint, which not only is a symptomatic arterial event plus the asymptomatic arterial events measured by CTA as arterial lesions, and you observe that you have an event-free survival, which is obviously different. The placebo is there, so you have more than approximately 50% of the placebo patients are already some arterial lesions progressing or symptomatic events at 1 year, compared to 80 to 90% event-free survival at 1 year for irbesartan, and the same observation at 2 years. So you had a strong effect with another ratio, which was 0.42, significant, even though we had a relatively low number of patients with the association of the irbesartan. This is exactly the same kind of thing, just giving you the numbers of them. So we had no cardiovascular deaths during this 2 years observation trial. You have the number of symptomatic arterial events. It's 3, not 5, but 6. I made a mistake there. You have the number of asymptomatic arterial events. And you have also there, when you are looking at the individual outcomes in patients, sometimes that's recurrence of a particular arterial lesions, you have there the number in the irbesartan and the placebo group, and you see that you have quite a strong difference, approximately more than the relative risk was about 40.4, which says that you have approximately more than two times events in the placebo group than irbesartan. And this can be followed by this, looked at by this figure. You have on the top the number of patients and the number of primary composite endpoints. So when you see the number of patients having an event, in the irbesartan, it's 8 patients. In the placebo group, it's 15 patients. And you see the number of events per patient, 5 to 1. That is, for example, in that case, For these 8 patients, 2 of them had 2 events, 5 had only 1 event, and this one had 4 events. When you look at the placebo group, you see that the difference is the distribution is different, with more people having several events, even though you can't want just one for each patient. And when you look this time at the events per patient, you see that in the irbesartan group, with the same exercise, for these 8 people, you had 13 events, and for these 15 people, you had 35 events. So it says that on one side, placebo plus celiprolol, you had an evolutive disease, at least in 8 arterial and symptomatic compared to irbesartan. It was very significant. We look at the possibility that this beneficial effect could be more on a particular region of the arteries compared to others. You see the number, the localization that we observe in terms of progression of lesions or new arterial lesions. And you see that you have approximately half of lesions in the irbesartan than in the placebo, 5 compared to 15, it's even 1/3. And at 2 years, it's approximately 1/3 also, 9 compared to 29. New lesions, progression. And you see there the effect on cervical arteries, thoracic abdominal arteries, visceral arteries, iliofemoral arteries. And you see that the effect is more or less diffuse, even though the probably it's not statistically significant, but the number of lesions which are the more important are in the abdominal visceral arteries, including the gastrointestinal arteries and the renal arteries, as well as the iliofemoral arteries. Finally, we look at the possibility that in different subgroups, the effect could be different. So you see that the beneficial effect was not depending on age. There is no difference. It seems to be better in males than females, but we have a very small number of males. So it's difficult to assess that effectively it would be more interesting to add this association in male compared to females. You see that the dominant negative mutations are have the same effect than the haploinsufficient. We do not have a sufficient number of subjects in the haploinsufficient mutation to be sure that you have an interaction with the type of mutation. You have the same effect in the exegesis and relatives. And we have the same effect depending on the arterial severity at the beginning. So it says that if you have already more than 5 lesions at the beginning, well, you might evolve more than if you have less lesions, but the effect of the treatment is the same. This is showed in these complex figures. You have in red there the event-free survival for the patients with arterial severity on placebo. That is, less than 20% of them have no progression of the disease. More than 80% of them have a progression of the disease. When we look at the effect of irbesartan with these people, you see that it's undoubtedly a strong effect, but it's something which shows at the end about 50% of them. When you look at the patients with no arterial severity, there you see that at the beginning, if you have less than 5 lesions, then the evolution is better, and it's even better when you are treated with irbesartan. So in each case, either you have less, you have an effect of irbesartan, even though the fact that you have a strong arterial severity, a number of arterial lesions at the beginning, say that you probably have a worse prognosis, but the effect of irbesartan in that case is quite interesting. So in conclusion, we have observed that we have a spontaneous progression of the arterial disease in the VEDS patient, even with celiprolol, that we have a reduction of event by about 50% when we add irbesartan, and this is already observed at 1 year, that we have a reduction of the lesions affecting all the arteries, especially the visceral arteries. We cannot say that we have a significant difference by subgroup because we have a number which are too small. The combination is well tolerated, except at the risk of arterial hypotension, especially in women. And the very interesting thing also is it's an inexpensive combination since these drugs are genericable. The limits is obviously the size of the trial. We have 60 patients compared to 100 which we are planned. There is a possible increased effect in men, but there is the issue of sample size. There is a possible need to reduce the doses, especially in women, to avoid excessively low blood pressure. We don't know about the specificity of irbesartan plus celiprolol versus irbesartan or any other ARB plus another beta blocker. We did not test that. We did not test either the efficacy of irbesartan or any ARB alone. Maybe it would be of interest. And it's interesting to observe in the future trial if we can generalize or not this result to asymptomatic patients, as well to patients less than 20 or 18 years of age. And I will just end up my presentation to say that we have submitted this manuscript for publication. It's currently under review. Thank you very much for your attention.
Thank you, Dr. Jounemet. We do have a couple of questions that came in via the chat, and I will pose those to you here in just a moment. But as a reminder, because the publication is still under review, this is not one of the webinars that will be placed on YouTube following the conference. However, there is a research replay on Friday. So if you were not able to watch this in full, or if you wanted to rewatch this webinar, it will be re-aired on Friday of this week. One of the first questions that came in, for patients that are unable to tolerate ARBs on top of a beta blocker due to low blood pressure, would you have a preference for which medication, beta blocker or an ARB, the patient should take based on this trial?
Well, it's difficult to say actually, since it's a case-by-case analysis, and we do not have a medical evidence in general to begin by either an ARB or the beta blocker if you have a difficult tolerance for one or the other. I would say that I would probably first take a beta blocker and see if it is or not tolerated, and then add an ARB. If it's not tolerated even at half dose, I would give obviously an ARB. My preference would be to have a combination at half dose of each drug.
Thank you. There's a question, just to confirm, those that were placed in the placebo group, they were continuing to take celiprolol.
Yeah, absolutely. I didn't show the exact dosage, but all patients were taking celiprolol, and you have a dosage at the end of the trial on average, which is similar to what we had at the beginning, which was about 350 milligrams on placebo. So yes, we tested the placebo plus celiprolol compared to irbesartan plus celiprolol.
Thank you. There is a question asking about how well celiprolol alone controls blood pressure.
No perfect data on that. We know that patients with VEDS have usually VEDS patients have usually a normal blood pressure, and celiprolol is not known to decrease blood pressure per se. And the percentage of hypertensive people in VEDS patients are relatively low, about 15–20%, depending on the age. So it's a difficult question to answer. Usually, it's not a drug which really decreases blood pressure, celiprolol.
There's a question that following the end of this. Oh, go ahead. I'm sorry.
Yeah. Are patients continue with combination the value trial site? So it was for us a very important question, obviously, and we did need to analyze the results before giving a guideline, I would say. But yes, the guideline is a combination of treatment. And once again, at half dose, if tolerated. Did you look at the number of vascular events in those who had other non-vascular events versus just progression of vascular disease? Events. I do not well understand the questions. The number of vascular events in those who had other non-vascular events. With GI or okay. I cannot answer to this question. We did not have sufficient power to have subgroups of patients with GI, for example, complication before, and see if their evolution was different to that of people without GI complication before. So interesting question, but I do not have the answer.
Thank you.
Would you expect similar results with an ACE inhibitor? Probably yes. I would suppose so. As you may know, the ACE inhibitors are well tolerated, and sometimes just in 10–20% of the cases are giving cough as a side effect. So I personally prefer, and I think it's in cardiovascular disease more and more given an ARB compared to ACE inhibitor. Obviously, the fact that you have in one case with an ACE inhibitor less angiotensin II itself compared to with an ARB, a blockade of the receptor, but more angiotensin II can be debated. But obviously, in most of the cardiovascular disease, the effect is more or less similar. Have you tried other beta blockers with an ARB like ARB? No. Once again, we began with celiprolol since it's more or less a reference treatment, at least in France, since the BEBE study and since we had a rather positive outcome in our survey. I have absolutely no particular medical evidence to say that celiprolol is better than carvedilol or vice versa in that particular disease.
Yes, so I typically don't have speakers that are engaged with the chat directly as well, and so usually I would be posing the questions to you, but thank you so much. That was very helpful. Yeah, obviously a big concern with regards to this combination of drugs is that celiprolol is still under investigation here in the United States, so it would be some time before someone would be able to take that combination of medications.
Yeah.
We will hang out just for a couple of more minutes here to see if any additional questions come in. As a reminder to the community, our Help and Resource Center is available to you to ask questions as well. So if you think of questions stemming from this webinar, after the webinar has been completed, you can submit those questions to the foundation at marfan.org/ask. Again, it's marfan.org/ask, and we can submit these questions then to Dr. Junemet after the webinar is complete as well.
Yeah. Thank you, Kelly, for your comments, for your personal comments that I received, and I'm sure that we will discuss furthermore in terms of research in another meeting.
We'll give it just a couple more seconds here to see if any other questions come in. As a reminder, on Friday of this week, there will be a replay of the research webinar, and this particular one will actually air on Friday, June 21st, excuse me, and that will air at 3 p.m. Eastern Standard Time. We've got another comment that came into Q&A that is just thanking you for this helpful information.
Yeah, thank you for this comment.
There's also another note that we should tell you. If you did not see the general session that was aired yesterday, that is already available on the conference website, and it's also already available on YouTube. So if you have not had the chance to view that, it is available for you to see already.
In addition, at 3 p.m. today, Dr. Cortell will be talking about the U.S. trial of celiprolol. And as part of that, Dr. Junemet is actually going to be joining us as well. And so in just under a half hour, if you would like to join us for that next webinar, Dr. Junemet will be joining us there. So take one last glance here. I don't see any additional questions that have come in. So Dr. Junemet, thank you so much for all of the important research that you have done. And thank you so much.
Thanks to you for the invitation, and thanks to all people to be connected and to share with us this important result, I think.
Thank you. Thank you very much.